The next session is in Management of Medical Emergency in Liver Disease by Dr. Ilankumaran Kaliamoorthy, CEO and Senior Consultant, Liver Anesthesia and Intensive Care, Rela Hospital, with more than 18 years of experience as Clinical Lead, Liver Anesthesia and Intensive Care.
Good evening, all of you. Before starting my talk, can I ask you a question? How many of you practice gastro or hepatology here? Can you raise your hands? How many of you practice gastro or hepatology in the city? None of you. Good. You might wonder why I have chosen this picture as a backdrop. It's totally unrelated to the medical field. I just wanted to communicate only one message here, which is liver disease. It's a burning issue right now. I can show you some slides where you can see the incidence of liver disease is going up, even the mortality is going up in the last 2 decades. As a clinician, we have to take extraordinary precaution while handling these kind of diseases now and in the future. As Dr. Dinesh clearly mentioned, the incidence of hepatitis B and C are coming down. At the same time, alcoholic liver disease and also fatty liver disease are going up. So we have to be extremely cautious. I don't know who has chosen this date for a liver CME. I don't know whether it's incidental or it's an accidental. Today is the World Hepatitis Day, and the theme for this year is bringing hepatitis care closer to you. And this is an appropriate platform to talk about liver topic. So this day is being celebrated as the Hepatitis Day because of Dr. Baruch Blumberg. He was an American physician, won Nobel Prize. He is the one who has identified hepatitis B virus and also developed a test to diagnose hepatitis B, and also he developed hepatitis B vaccination. So this is a real appropriate day to celebrate this day as a Hepatitis Day. As I said earlier, the incidence and prevalence of liver disease are going up. I have worked in the UK for 6 years before coming back to India. When I returned back to India, in our hospital where I have joined, there's a global hospital, there was no liver intensive care, dedicated liver intensive care. In 2009, we have created one designated liver intensive care with 11-bedded ICU with 4 intensivists, around 26 liver ICU nurses. But over the period of time, the requirement has gone up. In 2017, before we left global hospitals, we created 2 liver intensive care, one for surgical ICU, one is for medical ICU, with 22 beds, 8 dedicated liver intensivists and 52 nurses. We have moved to Rela Institute 3.5 years ago. Now the need is growing up further and further. Now we have 36-bedded liver intensive care unit with 130 nurses and 12 liver intensivists who is doing only liver ICU job. So that's a need for liver ICU and the care for liver patients. This picture will also clearly tell you that liver disease is one of the top 10 causes of mortality in our country. It's almost, the mortality is almost equivalent to diabetes mellitus. In terms of overall mortality, liver disease contributes 3.17% according to the recent data. Even the burden of liver disease and the mortality is going up over the period of time. This is the data until 2016. You can clearly visualize that. So today I am planning to cover commonest medical emergencies in decompensated cirrhosis and a little bit about acute liver failure. I also know the time, it's 8:50. I know that you're all waiting for dinner. I will try to close within 5 to 7 minutes. So this, Dr. Dinesh has already covered the stages of liver damage, stages of fatty liver damage. The healthy liver, the initial stage is non-alcoholic fatty liver. It processes into steatohepatitis and then cirrhosis. Later on, patients will also develop hepatocellular carcinoma, where there may be a requirement for liver transplantation or there may be a complete contraindication for liver transplantation. So there are a few stages of cirrhosis. The first stage is pre-cirrhotic stage. You won't face much of problem. Even you won't even diagnose patients at this point of this stage. The next stage is compensated cirrhotic. There are 2 stages in compensated cirrhotic, where portal venous gradient pressure will go up, and in stage 2 patients will also develop esophageal varices. In decompensated cirrhotic patients, you will start seeing a lot of clinical issues. Those issues I'm going to cover in the next few slides. When you get a patient with a liver disease, one of the easiest tool where we can find out what stage the patient is in, MEL score will give you some idea, and this will also help you to find out whether the patient is going to survive for how long. There are three important parameters you need to look into. One is creatinine, second one is INR, the third one is bilirubin. You can add sodium on top of it. You have applications, apps available in both the Google platform and an iPhone platform where you can easily calculate MEL scoring system. If the MEL score crosses more than 20, the chance of patient dying within 3 months' time goes up very significantly. So this is the time where we have to be very cautious and think about doing a transplant for this kind of patients. We have seen it before, alcohol and overeating, obesity or fatty liver increases the chance of cirrhosis. So in terms of medical emergencies, there are many medical emergencies you can see in decompensated cirrhosis, but I'm going to cover the top 5. The first one is hepatic encephalopathy, second one is coagulation abnormality, third one is variceal bleeding, fourth is renal failure or hepatorenal syndrome, the fifth one is bacterial paternity and sepsis, hydrothorax, pleural effusion, portal vein thrombosis, acute on chronic disease. It's all a wide topic I'm not going to cover in today's discussion. So when the patient comes to emergency in your clinic or in your hospital, we need to find out what stage the patient is in, whether the patient is already listed for transplantation or undergoing transplant workup, or there is a contraindication. With this information will help you guide your management and decision making. Hepatic encephalopathy can be due to multiple reasons. One of the reasons is cirrhosis. We name it as a type C. If you look at the pathophysiology, that's quite complex. In normal liver, urea is being produced in the liver because when the urea cycle is very active, this urea will get converted into ammonia in the colon. It goes into the portal system, coming back to the liver, and again it's get metabolized. So there's a normal cycle. But when there is a liver failure, when there is a urea cycle defect, whatever urea goes into the colon produces ammonia, but the ammonia when comes back to the liver won't be able to metabolize into urea. So this ammonia will go into multiple parts of the body, including muscles, brain, and all these locations. Especially brain is the first organ which will get affected if the ammonia level goes up. Ammonia joins with the glutamate, gets converted into glutamine, which is hyperosmolar, where it draws a lot of water into the brain cells. That causes edema and causes hepatic encephalopathy. And if you see a patient in your clinic, you need to assess what stage the patient is in. If the patient is in stage 4 comatose, the treatment varies. First 3 stage you can manage conservatively or needs close observation. So there are 2 important questions we have to answer. The first one is hepatic encephalopathy the primary reason for encephalopathy or altered mental status? The second question is, what has precipitated hepatic encephalopathy? We need to rule out sepsis, uremia, alcohol withdrawal, and intracerebral hemorrhage when you get a patient with hepatic encephalopathy. And there are many precipitants of hepatic encephalopathy we need to rule out, including medication non-compliance, GI bleeding, hypokalemia, alkalosis, dehydration, sepsis, constipation, all these things. As I said earlier, ammonia plays an important role. We have to check the ammonia level. It will tell you if the ammonia level is normal, you can do hepatic encephalopathy. CT scan, even though the patient is confused, we don't do CT scan immediately. But if there is no response to treatment, we can consider CT scan. So the key management principles, we have to protect the airway first because the risk of aspiration is pretty high. And then we have to treat the precipitating causes, fluid resuscitation, correct the electrolytes, treat the sepsis, and correct hyperammonemia with lactulose and rifampicin. So the role of liver transplantation, if you have a recurrent or persistent hepatic encephalopathy, that itself is a clear indication for liver transplantation. So these patients needs to be sent to one of the liver transplant centers. Upper GI bleeding, it's a very common issue with the liver disease because when the liver becomes stiffer in fibrosis or cirrhosis, the portal venous pressure goes up. That causes splanchnic vasodilatation. That further leads into dilatation of all the vessels, including esophageal varices. So this esophageal varices is the commonest site of bleeding in cirrhosis. And there are many complications which could arise from upper GI bleeding, including aspiration pneumonia, sepsis, hepatic encephalopathy, renal failure, and shock. So the key management principles, we have to aim for the hemoglobin of 7, maintain adequate perfusion. At the same time, please don't over-transfuse. Over-transfusions, that itself can cause portal venous pressure that can increase the bleeding further. Bacterial translocation is very common in bleeding. Start prophylactic antibiotics. Hemorrhage control needs to be done with the endoscopic variceal band ligation or therapeutic octreotide or somatostatin along with the band ligation. Balloon tamponade might be required in rare cases. Hepatorenal syndrome, I'm not going to cover the pathophysiology. It can happen because of a splanchnic vasodilatation and increase in renin-angiotensin-aldosterone system. And it's one of the most probable cause of acute renal failure in end-stage liver disease. It normally causes rise in serum creatinine, oliguria, normal urine sedimentation with the urine sodium less than 10 milliequivalents. Previously, they were called as HRS type 1 and type 2. They have changed the name into HRS AKI and HRS NAKI, non-acute kidney injury. So the management include some of the patients with the complications might need ICU admission. If the patient is very stable, we can just give octreotide, mirodin. Albumin is very useful in the situation. Vasopressins like terlipressin, norepinephrine might be also quite useful. And some of the patient not treated or getting responded to medical management might need continuous venous filtration or hemodialysis. Cochleopathy, there are many reasons, not only drop in clotting factors, decreased platelet numbers, poor nutritional status can cause it. INR or rise in APTT are not the right tools to give treatment. We have advanced modalities like thromboelastogram and rotum for treating coagulation. So if you drive a car, if there is no headlight, you will hit something. This is a typical example of how you need to treat the coagulation in cirrhotic patients. You need to have the right tool to find out what's the reason for the bleeding and then treat it accordingly. So the key management principle is aim for the platelet of 50,000, fibrinogen of more than 100. We have to avoid over-transfusion. I'm telling again and again, vitamin K may be useful in some of the situations. Bacterial paternity, that's one of the other reasons why patients gets admitted into the hospital. So bacterial peritonitis can be confirmed if the polymorphonucleic cell count is more than 250 cells in the ascitic fluid. So SBB can be treated with the antibiotics, albumin, and some pressor support and octreotide. Acute liver failure, I think it's a very too complex subject to discuss at this point of time due to lack of time. If you see a patient with the acute liver failure, there are few things we have to keep that in mind. We have to recognize acute liver failure early. We have to understand the etiology. Some of the patients we might not even know the etiology. Protection of the airway is really important. You have to get an intensivist to see them. Cerebral edema and increased intracranial pressure are the commonest cause of death in acute liver failure. So we have to protect the brain. We have to prevent further complications. And then we have to refer this patient to a liver transplant center. There are many tools we use in ICU to treat ALF. So to conclude, in chronic liver disease and acute liver failure, we have to recognize the disease and emergencies very early. We have to plan accordingly, and then we have to prevent further organ damage, and then we have to refer these patients to a liver transplant center where that option is available. Thank you very much for listening. I think I have kept my promise, finished in 10 minutes. Thank you.